Hello, everybody. Happy New Year. So today we're continuing our Cardiovascular Critical Care Core curriculum, or C5 as I decided to call it today on my way over here. So far we've covered, for those of you who have been to my lectures, we've covered acute MI, we've covered valve disease, mostly aortic stenosis, we've talked about emergency tachyarrhythmias and a little bit about bradyarrhythmias, and today we're going to talk about probably my favorite subject, which is shock, and why the CCU is fun. So this is going to be very interactive, and remember that I'm not athletic, so if I hurt you with this, sorry. Okay, who wants to tell me what's the definition of shock? How do you define shock? Okay, good. Hypoperfusion. Who said that? Way in the back. Woo! Yep. Nope. That's not even close. Okay, good. All right. You can get it if you like. These are very light. They don't travel as far. Hypoperfusion. Okay, good. So you have to have evidence that your end organs have been hypoperfused. Give me some examples of organs that can be hypoperfused and how you'll know. Okay, urine output for the kidneys. Good. And that's more important than creatinine, right? Because creatinine takes, 24 hours to come back, but the urine output shows you immediately. What else? Someone said liver. How do you tell the liver's underperfused? Hi, VA. Hi, guys at the VA. They can't hear me. There they are. Hi. Okay. How do you tell the liver's underperfused? So that would be liver dysfunction. You could eventually get there. How about in the acute setting in the first 24 hours? So let's see, shock liver, huge transaminases, right? I'm just going to start throwing this out. These are not going to be good. Good. All right. Well, some people will find some candy afterwards. Okay. So good. Shock liver. It's in the name. Good. What else? What other organs can be underperfused and how would you know? The brain. How would you know the brain's underperfused? Good. So they might become foggy and alter mental status. These are heavier. Nelson, you're going to have to throw candy to everybody for me. Thank you. Or you guys could just move closer, then you can get candy and learn something. So we've hit brain, kidney, liver. What other organs? Good. How much you know the heart's underperfused? Yeah, so we might see a troponin elevation, absolutely. Or you might actually see ST changes on an EKG, but then we're truly talking about a supply and demand phenomenon in that setting, right? Okay, good. So meaning that the supply is not provided for the amount of demand you have in the setting of shock. Okay, good. Those are pretty much some of the main organs. Now how about some hemodynamic definitions for shock? How do you define it? We're not going to get to the good stuff if you don't answer me. Hypotension! Thank you! Oh, yeah. Thanks, Nelson. Good job. Okay, hypotension. And what would you use? How do you define hypotension? Because, if you go in the NICU, have you guys ever been in the NICU? It's a horrifying place. And in the NICU, all the babies have MAPs of like 35. So, is that normal? Not in my world. So how about for an adult? How do you define hypotension?
MAP under 65.
Okay, good. So MAP under 65. And for me, I usually will say 60 is my goal, but under 65. And then technically in the definition of shock, you can use a systolic less than 90. That breaks down in patients who have chronic cardiomyopathy, right? Because they live with low blood pressures. So here we go. Hypotension, MAP less than 60, systolic less than 90, end organ perfusion. We hit most of these. We forgot bowel ischemia, right? We often will see that in the MICU. Okay, good. So today, my main point and the main goal of what I want you to get out of this lecture is when you think about what type of shock a patient is in. So first you establish they're in shock, which took us a little while to do. You should be quick with that, yeah? And then once you know that they're in shock, you're trying to figure out why. What's the type of shock? Because the treatments are going to vary drastically. And so the main take-home message of today's lecture is I want you to always be thinking about what is the primary insult behind this type of shock. Because all your treatments should be aimed at the primary insult, not all the body's compensatory mechanisms. So, name me, for one foot body part, name me a type of shock. Okay, septic, otherwise known as? Good. Someone gets candy. Nelson again. Okay, so good. So I could also get a designated thrower for me down here if anyone likes. Septic shock. Okay, good. Otherwise known as distributive. What's another kind of shock? Cardiogenic. You get a brain. Woo! Oh my gosh, these are really too light. You have to move down here. Okay. Did you guys sign the waiver before you came in today? Thank you. Cardiogenic shock, my favorite kind. What other kinds of shock do we have? Okay, hypovolemic. Yes, that one works. Woo, almost. Don't hurt yourself. Okay, and then the last kind of shock that we hopefully don't see very often, but we may. Good, neurogenic. Oh, of course, Dimitri says neurogenic. I'll give you a brain candy, or maybe an eyeball candy. Where'd you go? There it is. You're going to have to get that. Okay. Thank you. Okay, good. This is much better. Except...
Just take the top out.
Oh, that's right.
Okay, it's going to keep working on it. Okay. So we hit all the types of shock. Okay, so now, you can get 2 body parts for this. I want you to name me the primary insult behind cardiogenic shock, and I want you to use a hemodynamic term. So your options are, you can talk about intravascular volume, which is measured by CBP. You can talk about cardiac output. You could talk about systemic vascular resistance, or you could talk about heart rate. So, in cardiogenic shock, what is the primary insult? Low cardiac output. Someone gets an ear. Nelson again. Okay, good. So, decreased cardiac output is the main primary insult in cardiogenic shock. How about in distributive shock? Good. Oh my gosh. Oh yes, I made it to the back row. Okay, good. So low systemic vascular resistance. That's key. Hypovolemic shock. What's the main insult? Volume, CVP. No one said that. No one gets this finger. And then neurogenic shock. So neurogenic shock, it turns out, is decreased systemic vascular resistance. We're going to try to stay away from it as much as possible today. Okay, so burn this slide in your memory because the primary insult is the main thing that you should be thinking about at the patient's bedside when you're choosing how you're going to treat this person who has a low MAP. Okay, so let's talk a little bit about pathophysiology. So your body has a few things that it preserves above all else. And MAP is the thing that it preserves above all else when it comes to hemodynamics. When I first started learning about the hemodynamics and cardiovascular system, I would get confused because if you start at the wrong point on a circle, you can reason yourself to the wrong answer, right? Because it's all connected to one another. So that's why you have to start with what is the primary insult, and you also have to know what does the body try to maintain at all costs. So the body tries to maintain MAP, and it will do anything it has to, even if it's detrimental overall. It will do that in order to maintain the MAP because it wants to keep perfusion to mostly brain and heart. Okay? There you go, Dimitri. I care about your organs. Here's the brain just for you again. Okay. So that's really, really key. In terms of the other time that I think about this principle is when it comes to pH, right? The body will preserve pH at all costs because if you get too far outside of the normal range of pH, your enzymes stop working, all kinds of bad things happen. So the body will do all these wonky things with the kidneys and with your respiratory status in order to preserve the pH, even if it's detrimental. So that's how you have to think about when you think about shock. So the treatment is always, always, always to correct the primary insult if possible, and then you try to minimize all of the deleterious compensatory mechanisms that your body has done because it's trying to maintain the MAP, but it might be hurting itself, particularly in cardiogenic shock. I said this 17 times. The body tries to preserve MAP at all costs. So, in order to know what the body's doing to preserve MAP, you have to go back and do some math. Okay, so how do you tell me what is MAP? How do you determine it? Using the measurements you can get from a sphygmomanometer.
So 2/3 diastolic, 1/3 systolic.
You got it. You get, another body part. I'm not going to make it anywhere close. So 2/3 diastolic, 1/3 systolic. If you can't remember that you spend more time in diastole than you do in systole. So that's why it's 2/3 diastolic and 1/3 systolic. Okay? And the goal MAP, like we talked about, in the MICU you're going to hear 65. If you ever round with me and I'm dealing with cardiogenic shock, I'm always going to choose 60 because I'm trying to choose the balance between the beneficial effects of perfusion and the detrimental effects of all the medicines that we use to maintain the perfusion. So I usually aim for 60 when we're dealing with cardiogenic shock, but in the MICU you're going to aim for 65. Okay, so then you have to think about cardiac output because, of course, this is a cardiology lecture. So how do you determine cardiac output? What are the two determinants? Excellent. Stroke volume and heart rate. Okay, now, how are MAP and cardiac output related? Now, in order to remember this, I go back to high school physics. Woo! my brain hurts already. And I remember this. Remember this equation? V equals IR. I think it's like Ohm's law. Is that Ohm's law? Yeah? Okay. So that's voltage equals current times resistance. I don't know why I can remember that, but I can. And so here's how I think about it in the cardiovascular system. So what is your current? What's the current flowing through? Hint, hint. Cardiac output is your current. What's your resistance? Systemic vascular resistance. Voltage is a change, right? Voltage is just a change across the system. So the change in pressure across the system is my voltage here. So what is my change in pressure from the moment my blood leaves the heart until the moment it gets back to the right side? What's right here? What's this pressure? The average pressure when my blood leaves the heart is the MAP. Good. And then my average pressure when the blood returns is? You got it. So the change in pressure across the system is MAP minus CVP. Oftentimes the CVP is negligible, so you'll see this equation sometimes with the CVP taken out. But if you're talking about someone in cardiogenic shock, the CVP actually might be quite high, right? It might be 10, 12, 15, 25. So MAP minus CVP, change in pressure across the system, equals cardiac output times SVR. So if I am able to measure two of these variables, then I can calculate the other, right? Remember that cardiac output is made up of heart rate times stroke volume. So if you're thinking about, remember, your body wants to maintain MAP. So its options, if it wants to maintain MAP, if one of these three things, heart rate, stroke volume, or SVR, is changed, it can change the other two in compensation. But that's not the primary insult, right? So we're going to spend a lot of time going through this. Now, for advanced hemodynamics 102, or maybe 202, we also can use the same principle in the pulmonary circulation. And we, as cardiologists, spend a lot of time thinking about the pulmonary circulation because of how it impacts the left side of the heart, how it impacts the right side of the heart, and also how it impacts things like transplant and VAD candidacy. But I can use the same principle. So my change in pressure across the pulmonary system, which is my PA pressure minus my wedge pressure, is equal to cardiac output times pulmonary vascular resistance. And if you've ever seen people talk about the pulmonary resistance, this is how we get it. Okay, so is everybody good with these equations so far? MAP equals heart rate times stroke volume times SVR. That's the main thing that we're going to use. So, now we're going to talk about how the primary insult happens and then the compensatory mechanisms for each kind of shock. So, for a Snickers, what is the primary insult in cardiogenic shock? Which of these and what happens to it? Decreased stroke volume in simple terms. I feel like that was one of you. So the stroke volume goes down, usually because of contractility. Okay? So then what happens if the stroke volume goes down and I want to maintain my MAP? What happens to my heart rate? And what happens to my SVR? Take a moment to think about that. Do you think it is beneficial or detrimental for a weak heart to get an increased afterload with increased SVR? Is that a good or a bad thing? That's not good for that heart, right? But the body's trying to maintain MAP, so that's one of the only options of what it can do. Similarly, think about this. So you may have admitted this patient before. So this is someone who has chronic systolic LV failure. They come in acute decompensated heart failure, and their heart rate is 110, right? And you're like, oh, get them those beta blockers. Pause and think for a second. Why is their heart rate 110? It's because of this mechanism, right? In order to maintain their perfusion, because their stroke volume is so low, because their contractility is weak and their cardiac output is low, heart rate is the only thing that failing heart can do to augment cardiac output. So that's a compensatory response. If you, as the enterprising young intern, are like, I know what to do for heart failure, beta block them. You could very easily put that person over the edge and tip them into cardiogenic shock and land them on my service in the CCU. It's happened lots of times. So think about main insult, compensatory mechanisms. Distributive or septic shock, which of these three gets hit? SVR goes down. And then what's the compensatory mechanism to the heart rate? And if your heart is normal, what happens to stroke volume? So that's why when you order an echo in the MICU, oftentimes you'll see ejection fraction 75% or greater, right? Because that heart is able to augment its stroke volume and it's emptying completely with every beat. That's all compensatory because of the low systemic vascular resistance. Hypovolemic shock? Yeah, so the stroke volume goes down because you're underfilled. Different reason than the stroke volume going down in cardiogenic shock. but stroke volume effectively goes down. You just don't have enough gas in the tank. Then what happens to heart rate? And isn't that the first thing you learn in med school, right? Someone's bleeding out, they're tachycardic, that's a sign. And what happens to SVR as a compensatory response? It also increases, right? These are the people, if you guys have ever worked in the ER, you did during med school or you do now, you're down there and the patient that's bleeding out, you need IV access, but you can't get it, right? Because they're so clamped down peripherally because they're so underfilled. So those are the compensatory mechanisms. And then neurogenic, I'll just give this to you, the SVR goes down. The heart rate also goes down, but that's because this is complex and all your baroreceptors and the normal physiology that we think of for the cardiovascular system is messed up, and that's all I'm going to say about neurogenic shock. Okay. Now you might be looking at that chart and be like, but wait a second. Some of those are the same, right? Hypovolemic and cardiogenic look the same. Well, that's not right. Well, if you're just looking at these three parameters, it is. So we have to be a little bit more sophisticated and think beyond just map cardiac output and SVR. And that's where we get into hemodynamics. So this is the fun stuff. How many of you have seen a swan be placed or have been involved in a patient who had a swan in place? So if you've rounded with me, we've had a couple of swans this year. It's rare, and I'm going to show you why it's rare, but sometimes we have to do it. So I'm going to teach you how to think about the normal pressures inside the heart and how we use a swan to help us differentiate between these types of shock. So your only options for answer choices are American currency, nickels, quarters, and dimes. Okay? That's how you remember this in very simple terms. If you are not from America, I apologize. But you should know this. Nickels, quarters, and dimes, okay? So, right atrium. It's just an average pressure because there's no systole or diastole for the atria, right? There's a little bit, but it's negligible. So what's your option? If you have nickels, quarters, or dimes, what's the pressure in the right atrium? Nickel, 5. Good. How about in the right ventricle? I need a systolic and a diastolic. Sorry? Nickel and dime. Okay, there's a nickel and... What's your RVSP that you see on echo reports? Right ventricular systolic pressure. What would normal be? A quarter, yeah? The RV pumps a little bit. So 25/5 would be the normal pressure for the right ventricle. And then how about once you get into the pulmonary artery itself? What would be the normal systolic and diastolic? Yeah, you got it. The diastolic goes up a little bit because you get a little more resistance, right? Those are smaller area that you're pumping through. So pulmonary artery pressure normal would be 25/5. And then if we get all the way to the left atrium, which wedge pressure, have you guys heard of wedge pressure before? I'm going to show you what that means. Wedge pressure is just a surrogate for left atrial pressure. So left atrial pressure, the normal, the average would be nickels, quarters, or dimes? A dime, right? And you have learned this when you've learned the definition of ARDS, right? In the definition of ARDS, remember that third criteria? Wedge pressure less than 12, remember that? Okay? That's because if your wedge is over 12, that's abnormal. So that means your left atrial pressure is high. So the normal left atrial pressure is about 10. Nickels, quarters, and dimes. Everybody good on this? You kind of tapered off towards the end. Does this make sense to everybody? Okay. So now, sometimes what happens is we can't tell what kind of shock a person is in. And so we float the bird, or the Swan-Ganz catheter, or the PA catheter, in order to help us understand what are their hemodynamics. And cardiologists will say things like filling pressures. We mean the pressures that are emptying into the right and left ventricles. We want to know the filling pressures, we want to know the resistance, we can get all kinds of information from these. So as you can see here, I just showed you this same chart, but with nickels, quarters, and dimes. In order to put in a PA catheter, this one's coming from the groin, so it's coming up the IVC. Normally, when we're doing it at the bedside, we go through the SVC, so it comes through the neck, and then it goes into the right atrium, through the right ventricle, out the pulmonary artery, into the out the RV outflow tract, into the pulmonary artery, and then we wedge it with this little balloon in one of the pulmonary arterioles. And when we do that, when we blow up the balloon, the tip of the catheter doesn't see anything proximal to it. All it sees is what's distal. So it's getting the reflected pressure wave from the left atrium. And so that's how we get a wedge pressure, and that's why it is a surrogate for the left atrial pressure. So I'll show you what this looks like in real life, or cartoon life. Okay, good. So here's what's happening when we float the swan at the bedside. So we put it into about 15 centimeters, we blow up the balloon, and we watch our pressure tracings as we go in. I know I'm in the RA, and then I go into the RV, I see a 25/10 pressure curve, or higher. Then I get into the PA, and then suddenly my diastolic's going to come up. Remember we talked about that? And then when I get out to this pulmonary arterial and the balloon stops me from going much further, I see a little wedge tracing. The whole thing dampens. Then we deflate the balloon. It goes back to a PA tracing, that 25/10 or so. And then I can reinflate the balloon, wedge it again. All I'm seeing is the transmitted pressure from the left atrium, and I see that wedge tracing. Okay? So that's how we float it. Now, how do we use it to determine cardiac output? Well, there's this portion of the Swan that actually can measure temperature. So this is the proximal part, and this is the distal part. And it can measure temperature all along this. So what I can do is I can infuse some saline right here. That saline will flow along with the blood, and how fast it gets to this part will determine how much it changes the temperature, right? Because it's mixing with all of the blood that's in there. So the amount of temperature change between here and here, when I infuse the blood, I can use that through some calculations to make a determination of how fast the blood is flooding and therefore what the cardiac output is. The blood is flowing. That's what I meant to say. What did I say? The blood is flooding? Mm-hmm. How fast the blood is flowing. So this is how we measure, one of the ways we can measure cardiac output at the bedside. So this is mostly just to give you an overview. I don't expect you to become experts in this, but I want to explain to you why it's important that if we ever need a Swan, that someone who really knows what they're looking at is there, and why we don't do this in routine practice anymore. So that's the thermodilution method of measuring cardiac output. Could you imagine some problems with that? What might make you have some artificial tracings or artificial results if you're just using the thermodilution method? You're making the assumption that all the blood at the proximal part reaches the distal part. So what might mean that there's not a closed system? Good. So if you have tricuspid regurgitation, not all of the blood is flowing forward, right? Some of it's going backwards. So that messes with your inherent assumption. And what other change to that system might make it not a closed system? Good. So if you have a VSD, ASD also could do it, but mostly VSD, then you're not, the blood that starts at the proximal is not the same as what ends. So those two things will greatly impact your ability to calculate cardiac output based on thermodilution. And guess what? Who has tricuspid regurgitation? Pretty much everybody. So this is really an inherently somewhat flawed method of looking at cardiac output. So using it to measure absolute numbers, problematic. Following trends in the same patient who has the same TR or the same VSD, that can be useful. But just keep this in mind if you ever see someone who has one of these and they're telling you numbers, you have to take them with a grain of salt. The way that I prefer to look at cardiac output with my Swan, because that's one of the main reasons we float this. I want to know, is it high or is it low, to help me differentiate the type of shock. You can use the Fick method. The Fick method takes into account that your body extracts oxygen from the blood as it flows. So oxygen consumption can be estimated based on a nomogram. Okay? And then I can calculate my AV oxygen difference. So I can measure the blood in my A, the saturation, right? Arterial blood saturation of oxygen. I can measure the oxygen in my mixed venous, and I know how much oxygen has been extracted from my system over that. And then I can use my assumed oxygen consumption and my measured AV oxygen difference to calculate a cardiac output. Okay, so that's fancy. You can put it into a computer or calculator system. The important thing to understand here is that you're using a different principle entirely to calculate cardiac output. This is a bit more reliable. It does break down when people are really ill. That oxygen consumption nomogram is probably not correct, but you can still use this in a bit more reliable fashion than the thermodilution. So if I ever have a patient who's in shock, we're trying to differentiate between things, I pretty much ignore the Fick cardiac outputs. I don't even have the nurses measure them, especially not at university because they don't do it that often. And I just calculate a Fick. And that helps me to understand a bit better. Okay. So if we talk about the PA catheter, I want you to understand a little bit here why we don't do this in routine practice. So you can do it for diagnostic reasons to try and understand what's going on. Do they have tamponade? Do they have what kind of sepsis or what kind of shock? You can also use it to tailor your therapies. You cannot ever do this if you have right-sided endocarditis. It's a great way to give someone the PE. Good job. If they have any sort of thrombus in the right side, or if they have a mechanical valve, don't do it. If you do, I will kick you in the shins. Or maybe I'll just give you lytics for fun and see what happens. Okay. And then some of the relative contraindications, if they have a fresh pacemaker in, you don't want to be floating your blind swan in there and then accidentally snag one of those pacemaker leads and pull it out. So you should do this before you put in the pacemaker if possible. If they have a left bundle already and you're going into the right side, you might knock off the right bundle on the way in. So it's not an absolute contraindication, but you'll see me always saying put the pads on that person in case you lose the right bundle while you're floating and put them in complete heart block. And then user inexperience. This is really huge. And pretty much everyone in this room except for me has user inexperience. Got it? Okay. They have all the risks that you might expect. They can cause arrhythmia. PA rupture can happen. I've done that before. Whoops. Happens. So you have to be very certain that this is what you want to do. So here's why we don't do this in daily life. There was a time about 15, 20 years ago when every heart failure admission got a Swan to tailor therapy. It made sense, right? We can measure directly. We don't have to mess around figuring out where their JVP is. We can just measure it we can measure what their wedge pressure is. We don't have to mess around trying to figure out, do I up-titrate their afterload reduction? I can measure their afterload, and then I can know what to do. This was a trial, the ESCAPE trial, where they took patients who came in just for routine admission for decompensated heart failure, and they measured their mortality based on whether they got the Swan or whether they did not. Now, once they got the Swan, the doctors could do whatever they want with it, so you have to keep in mind that maybe they didn't know what they were interpreting. The other problem with this study is that nasiratide, which you've probably never seen, it's a drug that we think causes something called lusitropy. We think that it helps to relax the heart. Hasn't borne out in clinical trials. At that time, nasiratide was in vogue. So a lot of these patients got nasiratide. So with those caveats, absolutely no change in mortality or readmissions based on whether you got the Swan or not. So we know that there was no worse mortality, which a previous study had suggested, but no improvement. So we no longer do this routinely. So take-home message, you should not be doing this routinely, but you should know what we're measuring and why if you ever happen to be on a service where we float these. Okay, so back to hemodynamics, which is why I even started talking about Swans in the first place. I can use my Swan to help me understand something called loading conditions, which help me differentiate between the types of shock. So preload for the LV is measured by the wedge pressure, right? That's the left atrial pressure. What does preload mean? Preload means that if I have a hose and I barely turn it on, it's barely getting any water trickling through it, how good is the output going to be from that hose? Right? Very minimal. That's the preload. If you don't fill the tank enough, you can't get good output from it. I got to really crank up the hose, fill the hose completely, and then I'm going to get good output from it. So the heart, in order to really get something good out, it has to be adequately filled. If it's too filled, then you're soggy and overloaded and you get pulmonary edema. So the wedge pressure is a measure of what preload my left ventricle is seeing. So that's key. And then tissue oxygen extraction is also key. Let's talk about tissue oxygen extraction for a second. So have you guys ever measured mixed venous or central venous O2 sats in patients in shock to try and help you differentiate the type? Raise your hand if yes. Okay, and did you totally know what you were looking at or no idea? Okay. So this is why this is a very powerful and easy to do test. So let's think about what happens to your blood, your hemoglobin, as it circulates. If you are in septic shock, well, let's say normally, me, I'm not in shock today that I know of. Although I did get my blood pressure checked yesterday, I was like 100/60. Congratulations, me. So, okay, let's say me, normal life. My blood is pumping through my body, okay? When my hemoglobin reaches my tissues, the tissues extract the oxygen and then return the hemoglobin partially unloaded back to my RV, correct? Then it goes to the lungs, gets reloaded with oxygen and out to the system. So in me, the percent saturation of my hemoglobin, which is what an oxygen saturation in the blood is, for me, a normal saturation when the blood returns is about what? Anybody know?
70.
Yeah, so about C average, 70-75%. That's just good enough, you pass, right? So that means as my blood has circulated, about 30% of the oxygen gets taken out, and the rest of it remains bound to hemoglobin. Okay? Everybody understand that concept. So now let's talk about sepsis. So in sepsis, is your blood flow fast or slow? It's fast, right? If I get septic right now, my cardiac output will hopefully go up, and I'll be pumping really fast through my system, yeah? Okay. So that means that there is not a lot of time, number one, for the tissues to extract oxygen. Number two, are my tissues themselves normal or abnormal in sepsis? Totally abnormal, right? That's part of what sepsis does. It's not just that it gives you decreased SVR. It also affects all of your metabolism at a tissue level. You get acidotic. So my tissues are not able to extract oxygen as well as they could. So fast blood flow means little time for oxygen extraction, abnormal tissues. So what happens to my oxygen saturation in sepsis? Try one more time. So I'm not extracting very much oxygen, right? Because my tissues can't, and the time is too fast. So therefore, when I get back here, my oxygen saturation is higher because I've extracted less oxygen. Conversely, cardiogenic shock is the flow of blood fast or slow? It's really sluggish, right? 10 liters a minute in sepsis, 1.5 liters a minute in cardiogenic shock. So the blood flow is slow. That means lots of time to extract oxygen. And are my tissues normal or abnormal in cardiogenic shock? They're normal, and guess what? They're oxygen avid. So, do I extract more or less oxygen when I get back? More. So therefore my oxygen saturation goes down. Okay. Does that make sense to everyone? So the short story is, in sepsis, your mixed venous oxygen saturation up, in cardiogenic shock, down. So if you don't have a PA catheter in to measure your true central or mixed venous saturation, you can take it off of your central line if it's in the right atrium. Send a blood gas off your central line, make sure you get a saturation off of it, label it central venous O2 sat, and that will be very helpful. If it's 45 versus 85, that tells me a ton. I don't even need my Swan probably at that point. Okay, so now you're armed with that knowledge. We're going to try this again. So in cardiogenic shock, our stroke volume is down because our cardiac output is hit. Compensatorily, SVR goes up, heart rate goes up. My wedge pressure is high in cardiogenic shock, right? Because my heart can't pump, so all that blood gets backed up from the LV into the LA, into the lungs. That's why we get pulmonary edema. So my wedge pressure is high, and my mixed venous O2 saturation is low for the reasons we just talked about. Hypovolemic was the one that looked the same. But remember, in hypovolemic, my wedge pressure, my tank is underfilled, right? Because my whole blood volume is less. So my wedge is not going to be high, it's going to be low or somewhat normal. And my mixed venous sat is going to go up because I'm really pumping through fast, yeah? And then in distributed or septic shock, wedge pressure also low because I'm vasodilated and all the blood is third spacing, and my mixed venous also goes up. Make sense? So I use these things at the bedside. These are things that I can measure, and this helps me differentiate between the types of shock. Is everybody with me so far? Okay, good. Is your brain hurting a little bit? It's going to hurt more. Volunteers. Okay, we're going to go through these together, and we're going to talk about which type of shock. So I've given you hemodynamics, map, normal, all abnormal. Let me give you a hint. All these people are in shock, okay? I've given you wedge pressure, stroke volume, cardiac output, systemic vascular resistance, and the CVP. And we're going to go through and decide what type of shock each of these are. So I want you to don't just name it out, talk through what you see. Who's a brave volunteer to do column number 1? Okay, let's go for it. What do you got? Talk me through.
So the first one, your map says your wedge pressure is elevated. It's taking preloads up for that too. Stroke volume's down, significantly. Cardiac output is down. And your SVR is up. So CVP also preload. So like the cardiogenic.
Sorry?
Cardiogenic.
Oh yeah. Oh wait. And chocolate. Fantastic. Lefty. Okay. Thanks, Nelson, for being my designated thrower. Excellent. So does everyone follow that logic that we just went through? So when you're at the bedside assessing someone, this CVP of 20 is this, right? That's my JVP. So that's why I'm feeling them to feel their JVP. And then, or not feeling them. If you can feel the JVP, there's a problem. I'm looking at their neck to see the JVP. And then I touch them. When I touch their legs, which of these am I trying to determine? Yeah, systemic vascular resistance. If the SVR is low, that means they're vasodilated. What do they feel like? Warm, vasodilated. If their SVR is sky high and they're clamped down, what do they feel like? Cold. So these two things I actually think about at the bedside. Okay, good. So number one is, of course, cardiogenic shock. Good job. Okay, next. Okay, Dimitri, and then you'll be my next one. Okay, talk me through.
So the next one, let's decrease to pressures, normal.
Oh, try again. Here's the normal. Yeah, really low.
Sort of low cardiac output, low, and resistance is high with really low CDP, so it's a high load.
Yeah. Does everybody follow that? So this, and this all look the same. So the way that we knew that this was hypovolemic is because of the loading conditions. Wedge pressure, empty tank. CVP, that means a JVP down here, empty tank. So therefore, hypovolemic shock. Excellent. Yep, you can do what you want with those. Okay. All right, volunteer here. Next one.
Okay, so the mean arterial pressure is low. Wedge pressure is normal. Stroke volume is a little bit elevated. Cardiac output is high. Systemic activity is low. And CVP is a little bit above normal, so it seems like distributive shock.
You got it. So this is the septic patient after they've gotten a couple liters of fluid, probably, right? I've got my CVP pretty decent, so my tank is pretty full, but look at this guy. Woo! But what's my primary insult here? This thing, right? SVR in the toilet. And so therefore, this is distributive shock. Excellent. You get 2 feet to stand on. Okay. Okay, fantastic. Now, these are not fair, and they're a little bit hard, but you can do it. Who's next? I shouldn't have said that. No one wants to volunteer. Come on, someone who's not afraid. Give me a third year. You guys are 6 months from being...
Look at Dr. Singh right there.
So, mean arterial pressure is low, and pulmonary blood pressure is high. Stroke volume is increased as well. Cardiac output is really low. SVR is elevated. CVP is high. That goes along with it.
I'm going to give you a little give me. Look at these two things and talk me through that.
So initially I would say it's like cardiogenic, but
so the stroke volume you told me is high, and yet my cardiac output is low. So what must also be going on? Nope. What determines cardiac output? Heart rate and stroke volume, yeah? So if my stroke volume is relatively normal to slightly high, but my cardiac output is low, it must be that my heart rate is low. So this is actually bradycardia. It's not fair, I know. But you've seen this, right? Or maybe you've thought about it. When the person comes in with a heart rate of 30 and you're wondering, should I call the fellow to put in some temp wires? This is what we're wondering. Are we underperfusing because the bradycardia is causing a significant reduction in my cardiac output? Sometimes not, right? Sometimes they have enough stroke volume to compensate for it. But if this person is in shock because of the bradycardia, that's the person that you float temp wires for. Start pacing them or give them isoproterenol or whatever. Okay, good. Excellent. You get some candy. We all know it's not going to make it all the way back there, but somebody give it to him. Here you go. I'm trying out for the shot put at Olympic trials next year. Oops. No. Who didn't see that? Anyone wants to do this one? Did everybody just see it when I flashed it up? Okay, so let's talk through it, okay? Math is low. Wedge pressure, empty tank. Stroke volume, super low. Cardiac output, super low. SVR high. But look at this. My CVP is high, but my wedge pressure is low. So there's a difference between my right and my left side. So there's fluid in the right, and it's not getting into the left. And therefore, this is a PE. You also think about this, right? This is the person you're pushing lytics on. Does that make sense? P.S. You shouldn't float a swan in someone who has a PE. Okay. But this is what you're thinking about when you're at the bedside assessing that person. You're looking at the, right? Haven't you learned about in tamponade and in bad PE? You look at the JVP to try and see. You're feeling them to feel what their SVR is like. Trying to understand, are we compromising my left-sided filling because of a large PE? Okay, Yeah, go ahead.
In the bradycardia study, could severe MR explain it if they have to go to look?
So that could be because, we have to think about this. So if this is a true cardiac output and not just a measured one, because all your measurements break down with valvular regurgitation. But yes, if this is the effective cardiac output that your circulation is seeing, that means that all your cardiac output is going backwards. So yeah, that could potentially do it. Although, and in that case, you also would have elevated filling pressures. Yeah, good call. Yeah.
In the second one, do you need the cardiac output to be less than 2.1 of pressors, of inotropes to call it cardiogenic shock, and could that be obstructive shock then?
So you need the cardiac index to be less than 2. Yes, correct. But this, I gave you cardiac output, so this is probably an index more around 2.
So could that be a similar picture of obstructive shock?
What do you mean?
Like a tamponade?
Yes. Hold on. Let's see. Yeah, absolutely. So the main characteristic that's going to help you determine tamponade, if you had a Swan, would be what we call elevation and equalization of the diastolic pressures, because all of the pressures inside the heart are subject to the same external pressure. But yeah, that's absolutely. This could be from something like tamponade. That's good. Your stroke volume probably shouldn't be this low in tamponade. Probably not. Okay, good. Great questions. Okay, so now we get to the part that you care about, which is treatment. I go to 130 or 115.
612, 115. Another second speaker here. There's some people out there.
Yeah, we're going to go until they get here because I have so much good stuff. We haven't even talked about ECMO yet, but we won't get there today. Okay, so we're going to say the type of shock, you're going to give me the insult, and you're going to give me the appropriate treatment. So for cardiogenic shock, what's the main insult? Decreased cardiac output, usually because of decreased stroke volume, okay? And what's the treatment? Oh yeah, I heard it. Inotropes. And that hits the primary insult. And then secondarily, what else do we do for these people? Afterload reduction, and we also diurese them, right? Because they have volume on board. So inotropes, vasodilators or afterload reduction, and diuresis. Excellent. Distributive shock. Who said that? I think you said. You get a brain. That was really smart. Distributive shock. What's the primary insult? Decreased SVR. So how do we treat this? Vasopressors. Totally different, right? Sort of. We'll get there. And then we also want to give them fluid to fill the tank, right? Because they have third space, which I didn't account for in these hemodynamics. This is different than this. Totally different. Please keep that in mind. Hypovolemic shock. What's the main insult? Volume, so decreased CVP is the way that I say it, or decreased volume. And how do we treat that? Volume first. And then while you're waiting for the volume to work, you also give them? Yeah, you do, right? Now knowing that is, now you're being like the body. You're trying to maintain the MAP at all costs, but you're doing something detrimental. So eventually you want to take those pressors off. But you do it in the meantime to maintain MAP because that is very important. Okay, fantastic. So now let's do a few words on cardiogenic shock. Okay, we have to hurry up, so I will go through this really quick. We'll come back to that in another time. So cardiogenic shock, you have to be in shock. Yeah, everybody's got that. Plus, the hemodynamics. You have a low cardiac output, or cardiac index just means it's normalized for body surface area. And then you have to have a high wedge pressure, right? We talked about that. Is my next person here or no?
They're out there, but you can finish. I already let them know that we are.
Oh, okay, a few more minutes. Okay. Let's just for kicks, a few causes of cardiogenic shock. It's a huge, long list. Somebody give me a couple causes of cardiogenic shock. Good, so a STEMI, absolutely. What else? There's so much more than that. Okay, STEMI, how about, technically, we were talking about this obstructive shock, so tamponade technically is a form of cardiogenic shock. Okay, valvular disease. So, what's that? Yeah, so if you have a long-standing cardiomyopathy and you get decompensated enough, you can end up going into shock. Or the person that you slam with beta blockers, their heart rate goes down, they needed that for their compensation. So good, a decompensation of a long-standing cardiomyopathy. Who else? Yeah, my favorite, stress cardiomyopathy. Absolutely, they can present in shock.
Essentially, any arrhythmia.
Good. So VT or VF, it's a good way to die or go into cardiogenic shock, okay? And rare, but I guess sometimes if AFib is fast enough and you have the right conditions, you could be in shock from that. Rare, but it's possible. What else? Talk about some valves. Yeah, so bad aortic stenosis that gets decompensated, or aortic stenosis that you give nitroglycerin to. Shame on you, you didn't come to my lecture. I'm kicking you in the shins. Aortic stenosis, you can go into shock from that, just because you're not actually getting the blood out from the heart, so your effective cardiac output is low. How about the person with aortic valve endocarditis that's sitting waiting for their valve to be replaced, and then all of a sudden they're just dead? What happened with them? Acute aortic regurgitation, absolutely. What other valvular disease can put you into shock? We talked about it on the hemodynamics a little bit, or while you were talking about it. So let's say they come in with an inferior MI, and then 5 days later, all of a sudden they're in shock. What are you thinking of? So the mechanical complications, which include, that one shouldn't give you shock. Let's make it worse than that. Okay, so a VSD can put you into shock, right? Because all the blood's going to be going into the right side instead of out. So a VSD, or a free wall rupture, that's death, really. You have like 2 seconds of shock and then death. And then, what else? I heard someone say it. Yes, so pat muscle rupture giving you acute MR. All your cardiac output goes backwards. That is a bad beast, and it's pretty hard to treat those people. If you can get them to the OR, you can get them to do okay. But good, so acute valvular regurgitation can also put you into shock. There's a few other things on here. Peripartum cardiomyopathy you can present in shock. Chemotherapy-induced, any version of cardiomyopathy that you have can present in shock. And then PE will also put on this list. Oh, I forgot this one. Acute myocarditis, very important. People who get acute viral myocarditis or giant cell myocarditis, whoo! Those people are sick as, but if you can get them through, they can end up doing pretty well. Okay. Rejection after transplant, big reason for a shock. Okay, so we have no time to go through all this. I just want to get to 2 important things. So diagnosis of cardiogenic shock. That's what I spent all this time at the beginning talking to you about the hemodynamics, so you can go to the bedside and try to understand it. So the symptoms of cardiogenic shock can be something like, my brain doesn't work so well, altered mental status, feeling foggy. And then they can have either progressive or sudden onset of all your heart failure symptoms, be they left or right-sided, okay? Then they're going to have hypotension, tachycardia, and here's the key, their extremities will feel cool. So if you've ever rounded with me, have I showed you guys where I feel for their coolness on their extremities? Not the toes, right? If you're 80 years old, your toes are going to be cold. My toes are cold from Raynaud's, fine. Okay, but where do I feel for the temperature? I feel right behind their leg. The reason is that in old people, all their little peripheral capillaries and arterioles are going to get clamped down when they're in any sort of shock. But if I feel beneath their legs, like right behind their calves, and they feel cool there, that's a sign to me that they're actually cold and clamped down, as opposed to warm and vasodilated. Now, one asterisk here. When you get severe sepsis and you're progressing through the stages of sepsis, eventually you're going to get clamped down, right? The body will compensate. So profound sepsis can also be cool depending on when they presented and where you're at, or you put them on vasopressors. So that person who's maxed on epi and levofed and dopamine and vasopressin, they're probably not going to feel warm because artificially you've clamped them down. But when they first come in the door, cool extremities really important. Elevated JVP, which tells me about their CVP, and then by surrogate tells me about their wedge pressure. So if I see this, and they're cool, and they're in shock, it's not sepsis. So if I see this, should you give them fluids? Not unless you want to kill them. And then you'll see all the signs of heart failure. The data you'll have, they probably have a low ejection fraction, but keep in mind, I had a patient with an EF of 10% chronically who would go to the gym and lift weights. Probably not advisable, but he would do it. So just because your EF says 10% doesn't mean anything, but this is helpful. Similarly, you might have someone who has an EF of 30% after an MI and they're in florid cardiogenic shock. So acuity plays a big role in this. So the number is not the only thing that matters. You're going to have an elevated lactate in cardiogenic shock, right? Because your tissues aren't perfusing, so they go into anaerobic metabolism and produce lactic acid. So that doesn't help me differentiate. Mixed venous, we talked about, low for cardiogenic shock, high for sepsis. And then you're probably going to have some signs of end organ malperfusion so that your tone will be up, okay? So how do we treat these people? Well, we need to diurese them because they have volume overload. We give them inotropes because of the low cardiac output. And then we sometimes, if their blood pressure can tolerate it, give them vasodilators, because if I can actually, these are the bad parts, and here's how I'm treating it. If I can lower the SVR with a vasodilator, I'm actually going to improve my cardiac output, which is the point. The wrong approach is just to do what you do for everybody. Okay, so lastly, 2 quick notes on the inotropes. We have dopamine, dobutamine, and milrinone. Dopamine is weakly acting on alpha, beta, and then dopamine receptors. The problems with it are tachyarrhythmias and heart rate. You've seen this. Dobutamine mostly acts through beta-1, so it mostly gives you what we call inotropy, or the actual squeezing function of the heart. A little bit beta-2, so it gives you a little bit of chronotropy, meaning increasing the heart rate, and it vasodilates the periphery a little bit. So this can also cause tachyarrhythmias. Milrinone doesn't act through alpha or beta. It does phosphodiesterase inhibition, so it works through cyclic AMP, calcium cyclic, cyclic GMP. So it increases contractility, inotropy, and it also vasodilates. So this can actually lower the blood pressure significantly, caution and renal failure. This is an important slide. This is how your inotropy changes, so your contractility, and here's how your SVR changes. So here's how it vasodilates you. Dobutamine, it mostly gives you contractility. It doesn't do a ton to change your SVR. Milrinone mostly changes your SVR, so it gives you vasodilation with a little bit of contractility. Nitroprusside, my favorite drug, all it does is give you afterload reduction. Do not ever institute one of these without talking to your fellow or your attending, okay? Because it can be dangerous. Vasopressors, you guys know this, but just to remind you that they all have a lot of alpha agony, which just increases afterload, and so that can be detrimental to the failing heart. Especially epi and phenylephrine is the worst thing to choose if they have decompensated heart failure and you want to give them increased blood pressure. So this is an important study, and this is what I'm going to leave you with. So when you're choosing how to treat these people that come in with shock and you're like, I don't know, I'm not sure, I can't float the swan, what kind of shock is it? And what do you guys usually choose as your first line agent to keep their blood pressure up? So levofed, what if they don't have a central line?
Yeah.
Or, whoop, you choose neo first, wow. Or, what do you guys do all the time? Maybe you don't do it. Dopamine, right? We throw it around like it's candy. Just give them a little bit of dopamine. I'm going to show you why my practice pattern has changed in the last couple of years. This is a study in New England Journal of patients in shock. All kinds of shock. About 1,500 patients. They were randomized for their pressor of choice to either levofed, norepinephrine, or dopamine. There was no difference in mortality at 1 month. This also carried out to 6 and 12 months. But look at, if you're in shock, that's a lot. 1 month mortality, 50%. It's not good to be in shock. So there's no difference between these two. But here's the key that I want to talk to you about. Higher incidence of arrhythmia in the dopamine group for the reasons I just showed you. A lot higher incidence, by double. Mostly AFib. And you've seen this, right? You start them on the dopamine, heart rate goes up, they go into AFib, then you start amiodarone, and then you call me. It's okay, I don't mind, but you know why. You did it. It's your fault. But here's the key. There was a pre-specified subgroup of patients in cardiogenic shock. It was small, 280 patients, but that's actually a decent size for trials about shock because it's just hard to enroll patients. So in this pre-specified subgroup, this is where there was higher mortality in the dopamine group than in the levofed group. Significant. Look at that. And then, if you look at the survival curves, so here's the levofed survival curve, here's the dopamine survival curve, totally separated out. So the dopamine killed people. The reason is, if you have cardiogenic shock and you go into AFib, that's bad for you, right? And also, as you increase heart rate, you increase the workload of the heart. So all of those things are really detrimental. And then if you look at by type of shock, their hazard ratios for cardiogenic shock, norepinephrine or levofed was better. So based on this study, even though it's a little bit counterintuitive because yes, norepinephrine does give you some alpha, based on this study, you're actually okay if you choose levofed, norepinephrine as your pressor of choice for all forms of shock. I won't yell at you, okay? And that's for the people who are really hypotensive and you can't maintain their MAP. When they're on the edge and on the border, like MAP's around 55 or so, those are the people that sometimes then I can give them the inotropes instead, okay? But like I said, don't put inotropes on without talking to one of us. So I urge you to exercise caution whenever you're treating people with shock. Think about the primary insult, figure out the etiology. Turns out you can give them all levofed, but then you have to think harder about what you're going to do next. Okay, the end.